Again, good afternoon. My name is Shamia or Mia. I am the Interim Viral Hepatitis Program Director with the Tennessee Department of Health, and I will be facilitating today. Today's agenda includes introductions and announcements, a didactic presentation on common mental health medication drug interactions with hepatitis C treatment by Dr. Clark Allen, an adult case presentation, a pediatric case presentation, and then an opportunity to ask some questions and go over some answers before we close out. Just a few quick reminders. In order to be eligible for your continuing education credit, please make sure that you have registered for this event through Southeast Age Education and Training Center. You can use the link that Clover just put in the chat, and that's also on the slide or the QR code. But it's really important that you go ahead and register as well. First, we will do some in-chat introductions and a couple of brief announcements. So before we get started, I would like everyone to take a second and introduce yourself in the chat. Please make sure to include your name, your role, your organization, and whether or not this is your first session. And if you are having any difficulties, feel free to reach out to Anastasia. She put her information in the chat as well and can help with any kind of technical issues. There we go. I see a few people adding their introductions. Awesome. So before we start with the presentation, we would like to open up the floor and give everyone an opportunity to ask questions related to viral hepatitis that perhaps you wouldn't otherwise have a place to ask. So anyone want to get us started? It can be a question related to previous didactics or just a new question. So we will pause and give everyone an opportunity to think about a question. I'm looking in the chat to see if we have any questions as well. I see lots of introductions. No worries about the camera, Candy. But those of you that do have a working camera, we're always happy to see you and get an opportunity to speak. Anybody think of a question that they want to ask, you are welcome to come off of mute and ask. Again, it can be any viral hepatitis related question. So let's see. I just wanted to say a big thank you for providing this service. I have a patient follow-up this week who has finished meds and was so very thankful for her care from the Tennessee Department of Health. Oh, I love that. Thank you so much. We are really excited to be able to offer this and couldn't do it without providers like you. So truly appreciate it. And we'd be really excited if you wanted to share a case presentation related to your patient in the future. Well, if anyone comes up with questions throughout the presentation, don't hesitate to ask. We can always circle back to this, but we do try to offer an opportunity to talk about hot topics and just different things that might be on your mind related to viral hepatitis. So we will move forward and get started with our presentation with Dr. Allen. So again, common mental health medication, drug interactions with hepatitis C treatment. So Dr. Allen, I will pass it off to you.
All right. Thanks for that introduction. Yeah, it first started out with just being psych medications, and then I kind of expanded it to other things that may be associated with mental health. So we kind of bridged it into more medications that way I can cover more different disease states that are associated with mental health. Next slide. No conflicts of interest to disclose for this presentation. Next slide. Objectives. We want to make sure we're looking at trends and statistics of mental health and associated with hepatitis C. So we want to look at some mental health statistics as well as things associated with hepatitis C. We want to be able to identify severe drug interactions that could be associated with mental health medications while on hepatitis C treatment, and then determine if those mental health medications are safe or they may need to be adjusted. And that's the kicker with this is anytime there's going to be maybe a dose adjustment, which you'll see that in the slides, if there's going to be a dose adjustment, it will always be with the mental health medication. There are different strengths of the hepatitis C medications. Those are just going to be in the pediatric patients. There's only one adult strength of medication, so it's always going to be the hepatitis C medication will be the constant, and there may be potential dose changes or frequency changes with the mental health medication. And of course, we want to make sure after we've looked at all these drug interactions, making sure we pick the right option for the patient based on if a patient's on an interacting med, we want to make sure we pick a medication that does not interact if we can at all possible. Next slide. Want to make sure we talk about and expose us to our abbreviations. The main ones we are familiar with, the top four, especially with the drugs. Vocabulary for Brentisphere, trade name Mavorite, is GP, and Ladipicire Sofosbuvir, trade name Harvoni, is LED Soft, and then Sofosbuvir Valpatisvir, trade name Eclusa, is Soft Veil. And then we've got different mental health medication classes here that you'll see on the charts, and I'll try to make sure I explain them again once we get to those specific slides. Next slide. We want to first start off with statistics and trends in this area or space of hepatitis C treatment. We can go to the next slide. I wanted to make sure we looked at data that was post-COVID. So I made sure I looked at drugs or studies, not drug studies, but studies that had looked at mental health after the pandemic, because there's been a lot of change in that space. And so we saw during the pandemic, 25% increase in that first year of there being an increase in mental health conditions during that time, specifically in anxiety and depression. And it has since come down some, but still there is prevalence of a higher prevalence of mental health complications or problems since the pandemic has started. So there's going to be, in turn, potentially be more patients on mental health medications that we need to be aware of that may need hepatitis C treatment. What goes on with that? Hepatitis C patients, they reported in a study that there were 67% of patients had mental health symptoms. That doesn't mean they're on a mental health medication. That just means that patients that were surveyed in that study that showed that they had at least one mental health symptom, and that can be anywhere from where's my slide of examples? It could be anywhere from depression, anxiety, post-traumatic stress disorder, psychological distress, insomnia, loneliness, suicidal ideation. So any one of those could be a potential symptom that a patient was experiencing, and that could lead to a mental health medication, or it could be not, and just depending on if they wanted to seek counseling or things like that. There's other ways to kind of tackle mental health. There is an increased likelihood because of that with drug interactions that patients can be on hepatitis C treatment. They might be on a mental health medication that could interact. And so there is that potential chance with there being more patients experiencing mental health conditions since the pandemic. I didn't want to leave out mothers during this. I wanted to make sure I found a study to kind of looked at what is the percentage of postpartum depression that patients experience who have just delivered a baby. So 10 to 15% is what I found in the studies that I looked at. So there is a potential chance that mothers who just delivered could be on a mental health medication as well, that we need to make sure we're monitoring and making sure we're avoiding any drug interactions that could be present there. Next slide. So we first start out with looking at the guidelines. You can go ahead and go to the next slide. Every time I talk about drug interactions, I want to make sure I circle back to the guidelines, and it's in the guidelines to always make sure we're assessing for drug interactions before we start the medication. There's a big list in the hepatitis C guidelines, and we're going to go a little more in depth from what they have in the guidelines listed. We're definitely going to cover what's there, but we're also going to go look at more medications that are maybe not there, that are fine to use, but also the medications that are present on drug interactions that need to be monitored, need to be dose adjusted, or maybe contraindicated in use with specific hepatitis C medications. Next slide. And I want to make sure I always mention my resources of how I collect my information on drug interactions. University of Liverpool has a great free interaction checker, the one on the left, the one in red, hepatitis C drug interactions. It's a great source for anybody because it is a free source. There is some limitations to it, and we'll talk about that shortly. And there's also paid sources that including LexiComp and Micromedics. I use both Liverpool drug interactions as well as LexiComp. I like to compare and contrast because sometimes they have different information, and I like to compare the two and make a clinical decision based on what each one is saying and which one is safe for the patient and for the outcome of treating the hepatitis C. Next slide. So we're going to talk about lots of different mental health medications, and we're going to mainly focus on antidepressants, mood stabilizers, anti-anxiety medications, stimulants, antipsychotics, medications for migraines, epilepsy, and sleep agents. I tried to do my best to get everything I could, but not be over the top and having too many medications in this, and I didn't want to put you to sleep. So I definitely put the sleep agents last on purpose. Next slide. So let's start off with the softball of medications that a lot of patients that we will see might be on these medications. These are SSRIs. These are the selective serotonin reuptake inhibitors. A lot of patients will be on these, and thank goodness there's not any interactions that we have to worry about. So that includes citalopram, escitalopram, fluoxetine, paroxetine, sertraline. All those medications are very common for ones that I see, and I'm not too worried about it because there aren't any medication interactions with the hepatitis C medication. So no interaction with gabapentinoid, modipazole, sofosbuvir, or sofosbuvir opacivir. So no issues there. So we can keep on moving. The next drug class is the serotonin norepinephrine reuptake inhibitors. This is a similar class to the SSRIs, also mainly used to treat depression for the most part. Also, no interactions here, so that makes it easy. Just remembering that SSRIs and SNRIs, there aren't any interactions to worry about with hepatitis C medications. The one to note on here, the milnacipran, that medication, it can be used for fibromyalgia, also for depression off-label. So that's kind of in the same class, but maybe not has its primary indication is not for depression, but I still wanted to include it as well. Next slide. Then we also wanted to transition into atypical antidepressants. These are medications that maybe don't have a specific class, but they all kind of fall into a unique class of being called atypical antidepressants. The story is still the same for bupropion, mirtazapine, vortioxetine. They're all similar as far as what that we don't have to worry about any drug interactions there. The main point to note that Brintilix is actually the old brand name for this. I missed that when doing my edit. So it's actually Trentilix now. That is the update to that slide. So just remember that in your notes that it's actually Trentilix now and not Brintilix. That was a similar drug name that they had to change it for those reasons. But yeah, no drug interactions for any hepatitis C medication for the majority of main first line agents for antidepressant. Next slide. Now this is the MAOIs, the monoamine oxidase inhibitors. They're kind of an older class of drugs, so I don't expect many providers or many patients to be on these, but I did want to include them just because they still have a space to be used for treatment of depression. They do have a lot of drug interactions, but not with the hepatitis C medication. So that's why you might not see this very often because they do have a lot of drug interactions with other medications in the market, just not the case with hepatitis C medications. So I did want to include them, as well as we've got a miscellaneous category. I couldn't really fit these specific medications into any other drug class, so I just kind of put them in miscellaneous. So Buspar, gabapentin, lithium, and pregabalin. No drug interactions with any of those. I tried to fit them the best I could, but I finally just gave up and decided on a miscellaneous tab just to make sure we still address them and let you know that there's no issues with any of those medications either. Next slide. We're almost through the medications that are primarily indicated for depression. So these are the tricyclic antidepressants, or TCAs. As you can see, I tried to list a bunch of them. I didn't list all of them, but I wanted to make sure I I gave the most common ones out there. So I looked at different lists everywhere to get the best experience or knowledge of which ones are most often prescribed. That way I have them listed here. Amitriptyline is the most common one. Sometimes it's not even used for depression. It can be used for sleep as well. Doxepine, imipramine, disipramine, all the ipramines there, nortriptyline, all of these medications used for depression, they do not interact or have any interactions with the hepatitis C medications. Next slide. And now these are going to be the anti-anxiety medications, or the BZDs, which is the benzodiazepines. So there's a couple interactions here that we want to make sure we look at. So we finally got some flags here, and I want to make sure we alert to the different symbols. So all you've seen so far is green diamonds, which everything means good to go. So now we've got a yellow triangle here. That means some monitoring may be required. So there may be some increased risk of side effects. And that's when I usually put up the triangle, is when there's increased risk of side effects that requires monitoring. It's not to say that you can't use that medication. It just means you need to counsel that patient on the potential risk of increased risk of side effect. Maybe a dose adjustment if they experience side effects, but I didn't want to put it as an orange box to scare people. Mostly just monitoring for these specific medications. That includes alprazolam, the liquid version of midazolam. That's mainly seen in pediatrics, and then also triazolam. Go to the next slide. So I've went pretty quick so far because we haven't had that many drug interactions. I want to make sure if we've got any questions so far, want to have an echo pause here for any questions so far through that. Did you see a drug that you weren't sure about, or did you see a drug, or was there not a drug that you maybe were expecting to see in any of those slides? So feel free to come off mute or type your questions in the chat box during the echo pause. I definitely want to make sure we have time for this, because I am going through a lot of medications, but in the interest of time, I want to make sure we have time for our patient case as well. So I want to try to make sure I toe the line of not spending too much time on a bunch of green diamonds, but also making sure I spend appropriate time talking about drug interactions. I'll give it a couple more seconds to see if anybody wants to come off mute or drop me a question in the chat. Okay, all right, if everybody's good, we'll keep going. So the next section is going to be stimulants. So most of these medications could be in the pediatric population, could be in the adult population. Most of them, as you can see, they're all good to go from a drug interaction standpoint, except for the bottom one. This is mainly going to be seen in the pediatric population. It can be used in the adult population, but it's for different indications. But for attention deficit disorder, it's mainly indicated in the peds population. So modafinil, or trade name Provigil. There is an interaction there specifically with it being a CYP3A4 inducer, and it wants us to definitely monitor that as far as potentially reducing, or it's going to potentially reduce the concentration of the medications, and that puts the cure at risk. So when I see something like that about there being an inducer of one of the CYP enzymes, which is associated with the metabolism of the medication for hepatitis C, it's across the board for all three of them. We want to be really aware when we see that, and we want to kind of look further into that to make sure we're making the right choice. So if I see a patient on modafinil, I'm going to really question if I can maybe change them to a different stimulant, or kind of look at the dosing strategy of it. I would prefer, there's different guidance between the Lexicomp and the University of Liverpool. There was Canadian information and there's US information, whereas Lexicomp said it was okay from the US standpoint, but then the Canadian guidelines said it wasn't okay, and then the University of Liverpool said it wasn't okay either. So when you get a mixed bag like this, I'm usually going to err on the side of caution and kind of saying maybe we should use another agent. So there's a lot of different things to kind of go with. You definitely want to talk with your physician about this one. If you see a patient that's being prescribed a hepatitis C medication and you want to, you might want to just talk about there's potential drug interaction that could put the cure at risk. And so that's the main thing I want to put by making sure we put a green or orange box on this one. Not necessarily completely contraindicated, but we definitely want to think about maybe choosing a different option. Next slide. Now, kind of shifting gears, these medications are the first generation antipsychotics, so they're primarily going to be indicated for patients with schizophrenia and maybe even bipolar. Could be some other mental health conditions as well, but mainly you're going to see these prescribed for schizophrenia. Lots of different agents here. Mainly, you're going to notice haloperidol, loxapine. Pimozide is the one that got the X's. We'll talk about that in just a second. Prochlorpromazine. It's a medication that's not necessarily used for schizophrenia. It can be used for other things, but I wanted to include it in the list just because it may be a common medication that you've seen before. Now, with Pimozide, the interaction there, it's an inhibitor. So notice on the last slide, we talked about an inducer potentially messing with the concentrations of the hepatitis C medication. With this one, there's the inhibition of that pathway. So there's a potential risk of concentrations of the drugs increasing on both sides. Now, for the hepatitis C medications, we're not really concerned about an increase in the concentration. There hasn't been shown an increase in side effects when that occurs. So we're not really worried about that aspect of there being an increase in side effects associated with the hepatitis C medication. But we are worried about it from the Pimozide standpoint. There is an increased risk of side effects with it that could be problematic, and we want to avoid that medication in gocapivir, preventasphere, trade name Mavorite, and then ledipasvir, sofosbuvir, trade name Harvoni. I wanted it to also be the same case for sofosbuvir, ledipasvir. It did not give it as an interaction on the other two, on either one of the interaction checkers. So I expected that to be the case, but because it just said it was a weak inhibitor, it probably was okay. It said it was okay with use with Sofvel, trade name Epclusa. Mild interaction with thioridazine. That one wasn't listed on either Lexicomp or the hepatitis C drug tracker with the University of Liverpool. It was only listed in the hepatitis C guidelines. So I wanted to make sure just to put that there as well. It listed as monitor. So just monitor for side effects. So there's probably potentially some inhibition there. And we want to make sure we monitor for side effects with the medication. So I assume that's what it meant. It didn't have it listed as red. I assume it's going to be just something to monitor while you're on the medication. Next slide. Then we want to follow that up with the second gen antipsychotics, also called atypical antipsychotics. So this is kind of the second line, or not second line, but the agents that came out because there was a less risk of extrapyramidal side effects with these medications. So more side effects associated with first gen, and then not as side effects with the second gen, and that's why they kind of gave them their own new class. So a lot of these you'll be more familiar with as they're more mainstays in the market now. Aripiprazole, trade name Abilify, brexpiprazole, Rexulti, clozapine. There's a lot of things to go on with clozapine. Lorazepam, trade name Latuda, olanzapine, paliperidol, quetiapine, risperidone. Now we notice we've got a lot of different boxes on this one. The main two I want you to point out is the one that have the orange boxes. So it's going to ask for a drug reduction in dose of aripiprazole and clozapine if you're going to be on the Mavorite plus one of those agents. There's going to be a reduction in the mental health medication and not the Mavorite. There's, like I said before, there's never going to be a change in the dose of the hepatitis C medication. It's just going to be the mental health medication. The other medications that are listed, they're all in the caution, monitoring required. So just monitor for side effects. And if there are side effects, we could potentially reduce the dose at that point, but it's not something where you need to reduce the dose on the front end. So I want to make sure I distinguish that of automatically knowing to reduce the dose versus just monitor it, counsel the patient to just let your provider or let you know that if you're prescribing it, that they need to reach out to their mental health physician to talk about side effects, potentially lowering their dose. That could be something of a conversation to have on the front end if you're more on the wanting to err on the side of caution. Okay, next slide. Now we want to switch gears. This is the migraine medication section. We've got a lot of orange boxes and a couple reds here. The main class that is going to require changes, or we'll talk about the ergotamines. Those are older medications, not really seen as much, but there will be a need for dose reduction if they're going to be started on gocapivir, preventasphere, or ledipasvir, sofosbuvir. Not the case with Sofvel, trade name Epclusa. But then we've got the next class, and they're all the same. So atogepant, rimegepant, ubrogepant, and the Apagibapant. They're very hard to say, as you can tell. Even I struggle with some of these. Trade name Qulipta, Nurtec, Ubrelvy, and Zazopret. These medications are in a class called calcitonin gene-related peptide receptor antagonist. They all have the same mechanism of action, and they're all going to require, or they're all going to have some inhibition of the P-glycoprotein metabolism. So it's going through a metabolism phase. The main thing with this one is there's going to be a reduce in the frequency to give these medications. So you don't necessarily have to reduce the dose. There may be dose reduction. There may be frequency reduction. Maybe every 48 hours you can only give it once every 48 hours, or maybe there's a dose reduction. And at the last medication, it's contraindicated. There's just too much risk of increased risk of side effects with these medications, and that's where the risk is associated. Increased risk of side effects with all of these medications coming out of that specific class. The bottom three are all injection medications that are used to treat migraines. And there's no interactions there, very minimal, that you're going to see interaction with medications that are injection medications. Next slide. And now we can move on to a section that is very popular in the hepatitis C guidelines. There's lots of medications that potentially be used for epilepsy or seizures. And so I want to make sure I covered all of them the best I could. We've got two different slides for it, so a lot to go over here. A lot of them are going to be inducers of the metabolism pathway, and that's why we're going to see X's here, because it puts the concentration of the hepatitis C medication at risk of getting to adequate levels to reach a cure. So that's why you're going to see aminobarbital, carbamazepine, esmocarbazepine, and then oxcarbazepine is also everything's red on all those except for there's a monitoring on Cocapivar brensocatib with oxcarbazepine. So triliptal is the medication that I'll lean toward. If I see somebody that's on that medication, I'll definitely lean toward Mavorite. In that patient population, the drug interaction checkers still want to proceed with caution with that. But I've had patients that have been on Cocapivar brensocatib and oxcarbazepine and do just fine and get cured. But we do still want to be aware that there are drug interactions that could potentially induce the metabolism, therefore lower the concentration of the hepatitis C medication while on these drugs. So lacosamide, lamotrigine, levetiracetam, those are all good. So there are options in the epilepsy arena that can be used as alternatives if you come across a patient that's on carbamazepine, to reach out to that provider and say, hey, we're wanting to treat this patient for hepatitis C. Is there an option that the patient can be switched to a different agent while on treatment? And you can tell them it's only going to be for 8 to 12 weeks, and then we can switch back to their appropriate mental health medication. Or if they want to switch altogether, that's also something that's happened in the past in my clinic, where the patient was on phenytoin. We switched the patient to levetiracetam, and then once the patient had completed treatment, they did not go back to phenytoin. They just stayed on levetiracetam, trade name Keppra, and the patient was appreciated that because they felt like there was less side effects with that medication. Every medication is going to have their own side effects, but they seem to like and tolerate the levetiracetam better. So that's also an opportunity for potentially get them on a medication that may be more tolerable as well. Next slide. And so here's where I was talking about phenytoin. This is the second half of the epilepsy medication. So when you see phenobarbital, phenytoin, primidone, rufinamide, those medications are going to be considered kind of a no-go in the hepatitis C treatment plan, as they're just inducers of the CYP3A4 metabolism mechanism, and they're just going to really tank the concentration of these medications to where they're not effective for curing hepatitis C. So those are the medications that you want to be kind of putting in the back of your mind and say, oh, that's one of those that had the red flag or the red X by it. I need to reach out and talk about that. But we also have medications like topiramate, valproic acid, Depakote, Depakine. Those are okay. And then I wanted to make sure I added some pediatric seizures, the Sabril or Vigabatrin. That's also one that can be okay in use. If they were on that medication, that can also be used for treatment of hepatitis C. Next slide. And then we're to the final stage of the drug interactions, the sleep agents. So hopefully everybody's still awake, but I did want to make sure we talk about sleep agents because there's some patients that can suffer from insomnia. And so we've got several medications listed. I tried to find the most common medications for insomnia, and we've got a couple here. There's only 2 with drug interactions, and they're both in the same class. as far as the Qvivic or Detorexant and then Limborexant. Those are medications that, one, you just want to monitor for side effects with the first one, the Qvivic trade name, and then with Limborexant, you just want to monitor with a glucocorticoid trade name Maverick. It prefers you to only have a dose no greater than 5 milligrams while on that medication if you're going to be on Maverick. So that's why it's got an orange box versus just the caution of monitoring for side effects with those two agents. Everything else is good. Isopoquone, trade name Lunesta, Meltion, Trazodone's good. As Zopiclone, Zolpidem, trade name Ambien. So all those are good. No interactions to worry about with those other mainstays in patients who need help with sleep. Okay, all right. Next slide. And of course, if you get to a medication interaction that you're not sure about, or if there's conflicting information, like I mentioned on some of the medications, you can always reach out to me or reach out to a pharmacist that you're familiar with in your practice or know one in the area. Feel free to ask them. And if they're not sure about how to interpret interactions, you can always reach out to me. I'm more than happy to assist and use my noggin to look at the research and kind of look at the information and the data to give a best clinical judgment that I can as far as what to do and how to treat that patient and what to do if there's any need for change or adjustment in their mental health medications. So make sure you follow up with the patient during treatment to make sure if they start anything new or if they change medications. Always make sure we look at drug interactions when they start or change medications just to make sure there's nothing new that might be conflicting with the hepatitis C treatment at hand. And also just being engaged with the patient over time during their treatment lets them know that you care. And so the old saying goes, they don't care how much you know until they know how much you care. It really speaks volumes to what I do. Patients really latch onto me sometimes because they really like that I'm very hands-on with them, and they kind of shows me that they really trust me and they want to just continue to be in my care. Even though I've treated them for hepatitis C, they still want my recommendations on things, even though that's my main primary goal, but they still want to ask me about other stuff too. So it's funny sometimes when I still get phone calls after I've already treated and cured their hepatitis C. Next slide. We can open up for questions. If anybody's come across any drug interactions that they saw in the second half, any questions, any comments, anything that wasn't there that you've seen in practice that you were questioning about, I can be more than happy to run a drug interaction. Most of the drug interactions that maybe weren't listed, it maybe was in the interest of space. There were some that I didn't put in there just because there was an interaction. So there's a potential that I didn't include every single drug in those classes just because of in the interest of space. I didn't want to bog us down too much.
So I see one question in the chat.
Okay.
Is there any correlation between increased depression, anxiety, irritability symptoms and hepatitis C treatment, especially with Maverick?
I would say I would have to look in there to see if there's any studies on that. Based on my experience, I have not seen that. Usually I see patients feel better after knowing that they're getting treated. It's probably not necessarily a placebo effect, but it's not something necessarily that the medication is doing to help their overall mental state, but they just feel better knowing that they're accomplishing something that maybe they've been trying to get taken care of for a long time. So I can't speak to Maverick being associated with increased depression or anxiety. Usually I've experienced the latter, of patients feeling better and more motivated now that they've known that they're checking the box off, that they're getting rid of their hepatitis C and moving on. Can you kind of speak to, do you have a specific example, Lindsay, of what of a specific patient case about that?
Yeah, so I've had historically two patients. One, both had a history of mental illness, both being treated prior to hepatitis C treatment, but one reported significantly increased depression symptoms. And then the other one, that was a female. The other situation was a male, and throughout the entire duration of treatment, just really increased irritability symptoms. Of course, provider was made aware, pharmacist made aware, but there was never any direct correlation made. But I also questioned too if environmental factors played a role. But I just didn't know if there were any actual studies suggesting any correlation.
Yeah, I haven't seen any, but that doesn't mean I can't look a little harder and see if there's anything associated with that. So I'm going to write this down as a question to myself to kind of see what I can find as far as research on that. But yeah, that's very interesting. Were they on any mental health medications at the time?
The female was, but I cannot remember what medication it was. But the male, I want to say no. It was
Okay,
just very significant irritability symptoms.
gotcha. Okay, I'll see what I can find, and I'll shoot you an email if I can find anything.
Awesome, thank you. And we're always happy to bring the topic back up, and if you find anything, Dr. Allen, and we can mention it to everyone.
Yeah.
It looks like I see another question. It says, Dorinda says, I know this isn't related to our mental health topic, but the only interaction I've come across with my patients are related to statins. Do you want to comment on this today?
I sure can. So yeah, that's the primary interaction that I'll come across. So statins and anything for heartburn is usually what I experience on a daily basis when I come across patient med lists when I'm considering a patient for hepatitis C treatment. So for statins themselves, they're the main. Can you give me an example of which statin, or you just want me? I can go through all the statins.
It's actually, in my patient's case, it was a low dose of lovastatin. So it was a patient assistance program. So I talked to their pharmacist, they flagged it. I had already looked up that it was just increased the effectiveness really of the statin, and the patient was super undertreated on their statin and on a really low dose. And I said, just let them keep taking it. I'm probably going to increase the dose when they come off their Mavorite.
Yeah, was it with glucocorticoid prevention for a trade name Maverick that they were flagging
Yes.
it, or was it?
Yeah,
Okay,
it was flagged under Mavorite. So anyway, when I talked to the pharmacist, we weren't particularly concerned. We let the patient continue it through their treatment. They didn't have any side effects.
Yeah, so the main concern, like you just said, is there's increased risk of side effects with the statin. So there's going to be increased risk of muscle pains or rhabdomyolysis in rare cases. So that's the main concern. It's not going to do anything specifically to the hepatitis C medication. It's just going to be increased risk of those muscle pains. So definitely with a low dose lovastatin, did you say it was 5 milligrams?
I don't remember for sure, but yeah, they were on a lower dose of it. And obviously that's one of the less problematic statins anyway. I talked to the patient briefly about, reporting these side effects. And I think I brought them back at a 4-week follow-up to reevaluate, go ahead and check a CMP and just make sure they weren't having any concerns.
Yeah. And then, so for atorvastatin and simvastatin and lovastatin, those are the three that are definitely going to be, they're going to say contraindicated with glucocorticoid prevention, trade name Maverick. And then they're also going to say that rosuvastatin needs to be 10 milligrams or less. And then pravastatin needs to be a dose reduction by 50% with with Maverick. And then there's also going to be just monitoring with pitavastatin and fluvastatin. I don't really see patients on those medications, but those are the main statins that I can think of. And so if I see a patient on lovastatin, granted, it's one of the lower intensity statin medications. Sorry, I'm losing my voice here. But usually I'll probably switch them to a different statin or start a different agent. If there's other drug interactions there present that leads me to start Maverick, then I'll probably stick with Maverick and then just counsel the patient on potential risk of muscle pains. But more oftentimes than not, if there's no other drug interactions that are steering me to glucocorticoid prevention trade name Maverick, I'll probably just pick Epclusa, Sivasavir, Patazavir, or Lentiviral Sivasavir in that case, just because I want to make sure that I'm avoiding contraindicated drug interactions that are definitely documented. I try to steer clear of those if I can. If I can't, then we're definitely going to counsel and document everything about we're aware of the interaction. We counsel the patient, all those type of things in that case. But yes, good question.
Okay, so just you might switch what brand name of antiviral you were using. Like for example, a lot of my patients have a history of heart disease. They already have stents. They have had a cardiac event or of some sort, and so they need to be on their statins, but they also need their Hep C treated. So that's the sticky part. I don't have anyone right now that I'm having to switch out, but just something to keep in mind for the future, because I definitely have a lot of patients with cardiac history.
Yes, and usually patients that have had history of cardiac events and had stents placed and heart attacks and things like that, usually I am more inclined to not switch their statin, especially if it's going to be Crestor or rosuvastatin or
Right.
atorvastatin, and they're going to
They
be
need
kind
that.
of the lighter dose. I'm probably not going to switch their statin, and then I'm going to try to switch it to the appropriate hepatitis C medication to be in line with that. And then I'll definitely talk to the drug company, or not to the drug company, to the insurance company, if there is an issue as to why I have to use a specific agent, because I don't like switching statins when we're talking about its secondary prevention of kind of cardiac events.
Yeah, my sickest patient with hepatitis C, I've put in a referral to get them in with a specialist because they have heart failure and heart disease, and they've got some cirrhosis with their liver disease with their hepatitis. So I'm just going to send them out, but they're on a stronger statin, so it's just important for me to kind of have an idea of what we're dealing with.
Yeah, well, just shoot me an email if you've got. You can send me their med list, and we can discuss. More than happy to.
Okay, thank you.
So thanks for the question and conversation. I think it's great to be reminded that we have to be mindful of other medication classes and such as well. And